least common positions was okay, the least common position we didn't tell you, but that is not important. And ileocecal, by the way, the most common cause is the fecal obstructions, and the bacterial we will be having the polymicrobials or the E. coli. Then McBurney points, remember, and remember the central scores. We having the migratory pain, then we having the anorexia, nausea, vomiting, tenderness, rebound tenderness, elevated temperatures, leukocytosis, shift for neutrophils. All these things will be seen. If the more than 7 mentals more than equal to 7, then it will be a high probability of the acute appendicitis. If less than 5, there is a less probability of acute appendicitis. Then remember this sign, very important sign, McBurney signs and the Rovsing signs. If the pain in the right iliac fossa, the McBurney sign. If the pain in the right iliac fossa on pressing the left iliac fossa, so we call that the Rovsing sign. So remember, we got the 2 score for the leukocytosis and 2 score for the tenderness that we already discussed. Okay. Other than that, what we studied? Then question number 106, we discussed already about all the frostbite things. If it is the superficial frostbite, it will be the white or the pale skins, and the patients will feel cold and the numbness. And if it is the deep frostbite, so there can be if it is the superficials or the first degree, the white or pale skin will be there. And if it is the deep will be there, then deep will be looks like the waxy or the bluish green. Deep will be the waxy or the bluish grains, and already we discussed all these type of the frostbites. So revise that topic. And the next question is about the patient is complained of the pain in the hip joint. So we have seen that the patient's hip joint, the leg is in the position of flexion, adduction, and internal rotation. So you can see FADIR, FADIR. What is that? FADIR. FADIR means flexion, adduction, and internal rotations. So you see the flexion, adduction, and internal rotations. So significantly, what we see the contracted, there is elastic resistance to the passive adduction or abductions. Major trochanter is located high above the Rosen lateral lines. A significant lordosis is present. Lordosis means like in the load positions. In the load positions. Then we will be having what is your provisional diagnosis. So what we have seen that here this condition, the iliac dislocation of the lip, we call this condition iliac dislocation of the lip. See, if you see the anterior dislocation, so in anterior dislocations of hip, what we see, there will be the FADIR. If the FADIR is there, means what we see that the anterior dislocation of the hip. If you see posterior dislocation of hip, so posterior dislocation of the hip, we call this condition as the FABER. So what is that FABER? FABER means that patient is having the flexion. After that, AB means abduction. The patient is in the abduction positions, and the leg will be in the abduction position, and there will be the external rotation of the legs. If this condition is there, what does it that means? That is a posterior dislocation. If you see the FADER, it means which dislocation? The anterior dislocation. And the anterior dislocations where we will be having set, that is known as the iliac dislocation of the hip. And in this condition, what we see, the femoral head will be displaced superiorly and anteriorly. The femoral head will displaced superiorly and anteriorly. So we call this as the iliac dislocation of the iliac dislocation of the hip. So this femoral head will be displaced superiorly and anteriorly out of acetabulum. Acetabulum, we know that where the femoral head will fit. So we having the acetabulum, and to those acetabulum, what we having, the femoral head will fit. So if this femoral head will displace superiorly and anteriorly, we call this as the iliac dislocation of the hip or anterior dislocation of the leg, acetabulum. Okay, so remember that if you have the anterior dislocation of hip, the fetter, remember the fetter, flexion, adduction, internal rotation. Posterior dislocation of hip, what you see, the flexure, abduction and external rotation. So remember the fetter and Faber, Faber, very very important things that you need to remember. Okay, other than what symptoms you will see in this condition, the symptoms, the patients will be having the severe pain in this region, where in hip region. Symptoms, what you will see, there will be the severe pain in hip region, there will be the severe pain in hip region or hip joints, and person will be having the difficulty in moving the legs, there we have difficult movement of leg. Okay, so these kind of the features you will see, there is some resistance to the passive adduction or abduction of the extremity, means movement will be the difficult, that you need to remember. After that, the next question, 3 weeks after the acute angina. So we have seen the acute angina is there, the patient is still weak, inert, subfebrile, retromaxillary lymph nodes. So what we have seen, retromaxillary lymph nodes are enlarged, tonsils are flabby, stick together with the arches, they are the purulent plugs. If you see the purulent plugs in lacunae, so what is the most probable diagnosis? So remember that if we have been talking about the so if you see the purulent plugs, what is that purulent plug formation? It occurs in the chronic tonsillitis. So this is the characteristic feature of the chronic tonsillitis. What is the chronic tonsillitis? This is the recurrent inflammations. It is a recurrent, inflamed and infected tonsillitis. Recurrent, inflamed and infected tonsillitis or the tonsils. So in this condition, what we see, there is a formation of purulent plug. We know that the like the purulent, like bacterial something. So we having, if the purulent plug something is given in the questions, it definitely talking about the chronic tonsillitis, because purulent plug is the characteristics of the chronic tonsillitis. What are the symptoms you will see? The symptoms you will see, like the patients will be having the sore throat, swollen tonsils, the swollen tonsils will be there, difficulty in the swallowing, and white or yellow spots will be seen on the tonsils. White or yellow spots will be seen on the tonsils, because it is tonsillitis. So these kind of the spots, there are the like very minor spot that we'll see. Along with that, the patients will be having the bad breath. The bad breath from the mouth or the foul breath from the mouth will be assumed, and after that the patients will be having some kind of the ear pain, the headache, all kind of the features we will see. Okay, the important you need to remember that these patients will be having the sore throat, after the swollen tonsils, then there is a white or yellow spot on the tonsils, and there will be the bad breath we will be feel. Now, and remember that very important, if you see the purulent plugs, the purulent plug will be the here, and purulent plugs, you can say the collection of the pus and other like debris particles, they will form a plug like structures, and they will give the appearance that is the purulent plugs. If purulent plug is there, what do you answer? That is the chronic tonsillitis. Okay. After that, the next questions we already done, that is the post thrombophlebitic syndrome. So post thrombophlebitic syndrome, or we call this as the phlebitic syndromes. This condition occur after the DVT. So we already discussed this condition. We see the brown induration of the skins. Whenever the complications of the DVT kind of the things, there will be the complicated to cause a venous ulcers, and after that there is a lipodermatosclerosis will be formed. So we discussed this question in the varicose vein. And what the treatment we will give? We will use the compression stockings or the bandage will be done. This question was also asked before. Compression stockings or the bandage will be given. And if it is the, tell me if it is the arterial bleedings, then what the prevention we will do? If it is the arterial bleedings, what the we will do? Then we will do manually. Manually we will stop the bleedings. So what we will see, if you have this is the varicose form. This is the varicose form. Now the post thrombophlebitic, it can be other form also. Like for example, if I say there are the three type of the post thrombophlebitic. The first one is what? That is the first one is that is the edematous form. The first one is the edematous form. If it is the edematous form, what we will see? The swelling and fluids build up. There will be the swelling and fluid will be build up. So that is the edematous forms. After that, second one, that is the ulcerative forms. The second one is what? That is the ulcerative form will be there. And what we will see in ulcerative form, there will be the open sore development. There will be the open sore development will be there. After that, the third one, that is the mixed form. The third one, that is the mixed forms. And the mixed form, what we will see, there will be the combination of edematous and the ulceratives. And it includes the mixed variety, it includes like the varicose veins, along with the because like example varicose vein, there will the swelling of the skin as well, or the ulcerative things will be there. So this is we call the mixed forms. Okay, so that is the we having three forms: edematous, ulcerative, or the mixed forms. Here we having the deep vein thrombosis here. So which kind they be having? That is the varicose form. After that, these questions you will done bandbox right side pneumothorax. After that, the next questions I told you already yesterday. Then after that, the examination of the dead who died from a hangings. Now see this question. This question is from the forensic medicine. Okay, what we have seen, there is a dead man is there who died from hanging. He died from the hanging. Revealed that cadaver spots disappeared when pressed upon and restored after 50 seconds. Rigor mortis was moderately expressed only in the masticatory muscles and muscles of the neck and the finger. Body temperature is given. Specify the type of the death. Okay, so this type of the questions, what you will do? So let's do it here. So we having the, like if you want to use the terminology we use, that is the thanatology. Thanato, T-H-A-N-A. Thanatology. We call this as the thanatology. What is that thanatology? Is a study of death in all aspects. The study of death in all aspects. So we call this condition as the thanatology. We call this condition as the thanatology. Now we having the more of the thing. The one things we already discussed, that is the clinical death. The clinical death we also call the condition as the clinical death. We also call this condition as the somatic death. We also call this condition as the somatic death. Other we having like the molecular death, where the cell or the tissues they will be completely dead. We call this condition that is the molecular death. And we also discuss some biological death as well. After that, if we talk about the, if like we having to do the some like we have to test to confirm the death, but that test will not be asked in your like there will the ICAR test, Diaphos test, Magnus test. Okay, now one keyword I show, then not the question will be asked, but one keyword I show in your questions, in which something there is a like if the cessation of respirations, if the respiration has been stopped. So for that we do a test to confirm that stop respirations. We do a test that is known as the Winslow test. We know that is the Winslow test. So what we will see, there will be, we put a water on the chest, put water on the chest, put water on chest. If we see the movement, that means that there is a respiration is present. If no movement has been seen of water, no movement means person is dead. So we do this kind of the test that is known as the Winslow test. What we call this as the Winslow test. After that they will ask you some postpartum changes, not postpartum, postmartum. Partum means delivery, martum means death. Postmartum changes. If you see the postmartum changes, now this postmartum changes can be the immediate, मतलब तुरंत आ गए, मरते क्या आएंगे तुरंत, अगर कोई भी चेंजेस आ रहा है तो उसको बोलते हैं immediate. Then we will be having the early, and after that there will be the like late changes will be there. If immediate, they will be occur within the few minutes. Then there will be the early, and the early includes like it will take hours to the days. It will take the hours to the days, and the late it will take the days to weeks. इमीडिएट में कुछ नहीं है, इमीडिएट में वही जैसे हमारे पास क्या होगा, लॉस ऑफ वॉलंटरी मूवमेंट, वी हैविंग द लॉस ऑफ वॉलंटरी मूवमेंट. अगर वॉलंटरी मूवमेंट्स विल बी लॉस्ट तो वो क्या होगा, इमीडिएट होगा. इफ द लॉस ऑफ वॉलंटरी मूवमेंट इज देयर, अलोंग विद दैट वी सी दिस देयर इज ए circulation will be lost, so loss of circulation. Other than that we see there will be the loss of respiration. Other than that what we see, loss of respirations will be seen. So these kind of the things we will see in case of the immediate. That we already know that if any voluntary movement, circulation, respiration, मतलब बंदा टपक गया, ठीक है. तो अगर बंदा टपक गया तो मतलब क्या होगा, voluntary movement गया, circulation गया, respiration गया. So these kinds will be gone. After that क्या होगा कि हमारे पास there is early. Now in early postmortem changes what we see, there will be the skin changes. There will be the skin changes will be seen. The skin changes will be seen. After that we see there is eye changes will be seen. Alger mortis, ये जो अर्ली वाला है ना, ये they will ask you this one, they will ask you alger mortis. उसके बाद livor mortis, और after that what you will see, rigor mortis. This is the important one. So you see there is a skin changes, eye changes, alger mortis, livor mortis, or the rigor mortis. Late after the, like if the we will not able to decompose that dead body, so what will happen in that body, the decompositions will be started. As you see some of animals who died, but we will not able to like burn that, or we will not able to bury that, so it will start the decomposing. So the bad smelling has been come because of the decompositions. After that उसके बाद क्या देखते हैं हम, autolysis will be started, and after that what will see, the putrefactions will be started. So these kind of the things we seen in case of the postmortem changes, the immediate, early and the late. Immediate we see the loss of voluntary movement, circulation गई, respiration, बंदा टपक गया. तो अर्ली में हम देखते हैं कि स्किन चेंजेस होंगे, आई चेंजेस होंगे, एल्गोर मोटिस होगा, लीवर मोटिस होगा, रिगोर मोटिस होगा. लेट में व्हाट वी विल सी, डिकम्पोजिशन, ऑटोलाइसिस एंड द पुट्रिफिकेशंस विल बी डन. ऑटोलाइसिस कौन से एंजाइम कराते हैं, चलिए बता दो मेरे को. द ऑटोलाइसिस इज डन बाय व्हिच एंजाइम, राइट इन चैट. Autolysis is done by which enzymes? Autolysis is done by which enzyme? अरे भाई ऑटोलाइसिस एंजाइम लाइसोजाइमल, याद है, लाइसोसोमल एंजाइम, ठीक है. तो लाइसोसोमल एंजाइम क्या कराएंगे, ऑटोलाइसिस कराएंगे. बट जो पुट्रिफिकेशन होता है वो कहां से होता है, ड्यू टू विच एंजाइम, द पुट्रिफिकेशन बाय द एक्सटर्नल बैक्टीरियल enzymes. Okay, so autolysis is done by the lysosomal enzyme that is present in the body itself, and we will be having then putrefaction, and the putrefactions what we will be having, that is the external bacterial enzymes. स्किन चेंजेस में क्या होगा, स्किन चेंजेस में होगा लॉस ऑफ इलास्टिसिटी. आई चेंजेस में क्या होगा, देयर विल बी सम like the person will be having the changes in the retina vessels, sclera, eye. Sometimes we will see the bluish discolorations will be there. Okay, other than that, so these kind of the changes we know already. The skin we will be having some loss of elasticity, the retina will be seen, there is a bluish of the eyes will be there, the retina fragmentations will be started, and the cornea जो है, the cornea will be looks like from the transparent to the opaque. Cornea don't have the blood supply, that's why it's transparent. बट उसके बाद क्या होगा, कॉर्निया के अंदर ब्लड सप्लाई नहीं होती, इसलिए वो ट्रांसपेरेंट दिखाई देती है. But now the patient is dead, so there is the fragmentations, and due to which we'll see the cornea will be going from transparent to the opaque conditions. Okay, after that the third one conditions will be there, and the third one what we see, that is the algor mortis. Third one what we see, the algor mortis. We call this condition as the chill of death. We call this condition as the chill of death. In algor mortis, what we see, algor mortis, there is a post-mortem cooling of the body. The post-mortem cooling of the body will be seen. The post-mortem cooling of the body will be seen, and when it will be seen, they will ask you the duration. So 15 minutes after the death, if you see 15 minutes after the death, what you will see, the post-mortem cooling of the body will be seen. बिकॉज व्हेन ए पर्सन डाई, जब एक पर्सन, कोई आदमी मर जाता है तो उसके अंदर क्या होगा, हीट लॉस होती है बाई कंडक्शन. हीट लॉस करने के 3 तरीके हैं, ये क्वेश्चन भी है आपके एग्जाम में. ठीक है, हीट लॉस करने के 3 तरीके हैं. कौन कौन सा, कंडक्शन, कॉन्वेक्शन और रेडिएशन. दिस वन यू ऑलरेडी डिस्कस इन Croc one time also. So they are the 3 types of the heat loss, the conductions, convection or the radiations. So through which what will be here, the heat loss will be there. Now the reduction of the body core temperature, the body will be undergo the hyperthermia, hypothermia. That's why the body will be having the cooling of the body will be occur. Okay, एक question और है, like not for Croc one, but they can ask you for the Croc also. Which is the site of, the best site to measure the, or the common site to measure the body temperature? So that is the rectum. So rectum is the good things, and this is the most common site where we will see, that is the most common site, that is the site to measure the body temperature. Okay. After the, you need to remember the time, 50 minutes after the death, algor mortis. 50 minutes after the death, what we see, the algor mortis. After the algor mortis, the fourth one will be, that is the livor mortis. The fourth one will be the livor mortis. What you will see in case of the livor mortis? The livor mortis, also known as the cadaveric lividity. Cadaveric lividity or post-mortem lividity. Livor में, in the case of the livor, remember there will be, when the persons will die, so there is a, in the person what we see, the blood in the vessels, the blood in the vessels. So like if the person is in the supine position, if the person is in the supine position, or the person is in the supine position, so if the person is in the supine positions, what will happen in that thing, there will be the pulling of the bloods, whichever the area is touching to the ground, whichever area is touching to the grounds, they are the dependent parts, they are the dependent parts. So what we will see, this area will be looks more bluish, this area will be look more bluish, and we call this condition as the post-mortem staining. So what you will see in livor mortis, post-mortem staining will be seen. But you see the post-mortem staining will be seen, and post-mortem staining के अंदर हम क्या देखते हैं, the area, the pooling in the dependent parts, there will be the blood will pools in dependent part. If the bloods will pool in the dependent part, so what we will see, the blood will the pool, so it will gives the bluish purple discolorations, will give the bluish purple discolorations, and we call this condition as the post-mortem stainings. We call this condition as the post-mortem stainings. Now देखो अभी, now the when the person is in the supine position, so it will be the back of the head. जो dependent part हो गए वो कौन कौन सा होगा, that dependent part will be the back of the head. After that, if I say that this is the back, if I say this is the back, this is the back of the head, back of the head, back of the chest, and there will be, and this, and patients will be here like this kind of abdomen, the back of the legs. So everything will be, that is the dependent part will be there, that will be the dependent part. Okay, so blood pools in the dependent parts, and we will see there is a, in these dependent parts, what we will see, there will be pooling of the bloods, and this area will be bluish discoloration. We call this condition as the post-mortem staining. Okay, is that clear? If it is the prone position, then front of the face we will see, the front of the chest, front of the abdomen, that will be the dependent area in the prone positions. Now whatever the positions, whatever the dependent part, that is the dependent part that is touching to the ground. Remember like that. The dependent part is that area that is touching to the ground. There will be, see, there is a blood will be pool in that area, and that will be looks like the bluish purple discoloration, and we call this condition as the which condition? That is the livor mortis. We call this condition as the livor mortis. Okay, after the livor mortis, what we see, that there will be the, okay, is that clear? And remember these things, post-mortem staining, it is a very important topic for further examinations like the FMG, and they will ask you one question for sure in this question, and they will ask you some like if the person is having some different type of the poisoning, whether it is carbon monoxide poisonings, methanol poisonings, so in different things we will get the different post-mortem stain. Okay, like for example, carbon monoxide, it will give the cherry red color, cherry red stain. In case of the, if person is under the carbon monoxide poisoning, so in the carbon monoxide poisoning there will be the cherry red post-mortem staining will be there. So that's why this topic is important. After that we will see there will be the fifth one, and the fifth one what we will see, there will be the rigor mortis. Rigor mortis. If the rigor mortis is there, this is also known as the cadaveric rigidity. This is also known as the cadaveric rigidity. Now what we will see in case of the rigor mortis, now when the person will die, so the muscles will initially, what they will be, muscles initially relaxed. Muscles what they would initially relaxed, because now body having the, what the body now like for example, if you having the hand of the dead body in your hand, if you have hand of dead body in your hand, so the muscles will initially relax. So starting you will see there will be the nothing, but once there will be the time increasing, there the stiffness will keep increasing. The stiffness will keep increasing, and that's why we will see there the, it will become the stiff muscles. There will be the stiff muscles, and these stiff muscles we call this condition as the rigor mortis. We call that the rigor mortis, because rigor mortis is due to which condition? ATP depletions. If the ATP will start decreasing, the rigor mortis will be there, because here the ATP is 100%. The ATP is here is 100%, but as the time going, so the ATP will start decreasing and the stiffness will be occur. These muscles will again relax. These muscles will again relax at the time of the decompositions. At the time of the decompositions, when the proteolysis will occur, again the ATP formations will be there. So then again it will become the undergo the relaxation phase. What is the onset of the rigor mortis? The onset of the rigor mortis is 60 minutes. The onset of the rigor mortis is the 60 minutes. So remember that is, if the onset of the stiffness, it will be at the 60 minutes or the 1 hour. Okay, is that clear? Now there is one question about the rigor mortis, that if the rigor mortis, we need to check about the progression. So progressions will be done with the help of a rule, and that rule is which one? That is the Nisten's rules. That is the Nisten's rule. And the Nisten's rule what say, that the sequence of the muscles, it involves the group of the organs. Like for example, there will be in the starting what we see the myocardium. The starting what we see, the myocardium will be having undergo the stiffness. After the myocardium there will be the eyelid. After the eyelid there will be the neck, then jaw, फिर face, then down, and then after that the lower limb, and after the lower limb what we will see, fingers and toes. Fingers and toes will be in the end. So that is the stiffness of the progression of the rigor mortis based on the Nistens rules. Based on the Nistens rules. There is a one more rules, that is the we call this rule as the Shapiro rules. But Shapiro rules, it is like based on the biochemical process, and it says that everything occurs simultaneously in all the muscles. But Nistens rules that everyone follows, that firstly it involves the myocardium, then eyelid, then neck, jaw, then thorax, firstly face, thorax, then abdomens, upper limbs, lower limbs, and then finger and the toes. That will be the like the sequence of the progression of the rigor mortis. It onset is 60 minutes, and 60 minutes it will be end around 12 hours. It will end around 12 hours. Okay, that you need to remember. Okay, so what was the question? So now you have seen that restored after 50 seconds. Now patient hanging, the cadaveric spot disappeared and stored after 50 seconds. Rigor mortis was moderately expressed in the masticatory muscles and the muscles of the neck on the fingers. Muscles of the neck and fingers. Body temperature specify the time of the death. So I told you what, that the onset is what, 60 minutes, and it end around the 12 hours. It end around the 12 hours. So what we have to know, that we need to remember the sequence. We need to remember the sequence. So for the sequence it will become so long. So what you need to remember, that cadaveric spot will disappear, pressed upon, restored after 50 seconds. Now we have seen that's moderately. So if it is a moderately, now what is the 0 to 12 hours? So moderate will be around 6 to 7 hours. Okay, if the moderately express is there, so what will be that? That will be the 6 to 7 hours. Okay, that you need to calculate. And the sequence I told you already, that is the myocardium, eyelid, neck, jaw, face, thorax, upper limb, abdomen, lower limbs, finger, toes. Okay, let me revise this quickly. What we have seen? We have seen that thanatology, this is the study of the death in all the aspects. Okay, we call this is the like the terminology used for the study of the death in all the aspects of thanatology. Clinical death is also known as the somatic death. Winslow test cause किसको बोलते हैं? Cessation of the respiration, postpartum changes, then the immediate, early and the late. Immediate मतलब बंदा तुरंत टपक गया, उसमें जो immediate changes होते हैं वो बोलते हैं. अर्ली में क्या होगा? अर्ली की यानी कि कुछ घंटों बाद, कुछ दिनों बाद क्या होंगे? दैट स्किन चेंजेस होगा, आई चेंजेस होगी, एल्गर मोर्टिस होगी, लिवर मोर्टिस होगी, और द रिगोर मोर्टिस होगी. लेट दैट डेज टू वीक्स, कि दिन के बाद कितना होगा, वीक्स में कितना होगा, डिकम्पोजिशंस, उसके बाद ऑटोलाइसिस, पुट्रिफिकेशन, जो बदबू आने लग जाती है तो मतलब बॉडी ट्राई टू डिकम्पोज, उस डिकम्पोजिशन के बाद लाइसोसोमल एंजाइम, फिर जो दूसरे बैक्टीरिया वो उनके बाद उनका क्या करना स्टार्ट कर देते हैं, पुट्रिफेक्शन, और पुट्रिफेक्शन के टाइम पे देयर इज ए लॉट ऑफ द स्मेल्स वी विल सी. एल्गर मोर्टिस दैट इज द चिल ऑफ द डेथ. चिल मतलब जो डेड बॉडी वो क्या कर रही है, चिल कर रही है. तो चिल कर रही है उसको क्या बोलेंगे, एल्गा में चिल कर रही है, एल्गारिया में क्या कर रही है, चिल कर रही है. क्या कर रही है, एल्गारिया में चिल कर रही है, दैट इज द चिल ऑफ द डेथ. लिवर मोर्टिस दैट कैडावरिक लिविडिटी और द पीएम लिविडिटी. तो लिवर मोर्टिस में क्या होगा, पोस्टमार्टम स्टेनिंग हो जाएगी. ठीक है, लीवर मोर्टिस, लीमोस क्या होगा, लीमोस. तो क्या बोलेगा, लीमोस. ठीक है, लीमोस. So there will be the staining will be there. So Li means liver mortis, and as for the staining will be the rigor mortis. What we will see, the muscles initially relax, stiff muscles relax, the compositions will be there. Okay, done. After the rigor mortis, we see the cadaveric spasm also, that is after the rigor mortis. The next question, I think same question, that is the 6 to 7 hours ago. After that, question number 114. After contusion of the right eye, a patient complained of the sudden loss of the vision and remaining light perception. Objectively, what we see, the eye is not irritated the cornea is transparent, pupil react to the light, pupil area is black. What you have seen, the pupil area is black and the fundus reflex is absent. So what is the most likely cause of vision loss? So what we have seen, there is a contusion. Now if we have the contusion, it means that the patient will be having the some blood loss will be there. So we called after contusion is there is a sudden loss of what? Vision with the remaining light perception, and the eye is not irritated, cornea is transparent, means there is no problem with the cornea and the corneal blood supply is intact, pupil will react to the lights, the pupil area is black, everything is okay till here, the fundal reflex is absent. Now what is the most likely cause? We have called this condition. Now we have the contusion is there, so contusions can lead to the hemorrhage in this condition. So if contusion will be there, we call this condition as the intraocular hemorrhage. The intraocular hemorrhage. This intraocular hemorrhage, it also known as what we call this condition, that is also called the hemophthalmia. This is hemophthalmia. That is the hemophthalmia. What we will see in case of the intraocular hemorrhage, it is classified based on the location of the bleedings. We can classify it is based on the location of the bleedings, because when we have see the intraocular hemorrhage, it is hemorrhage or the bleeding that is occur inside the eye. Now what we will see that in this condition, it can include the anterior chambers, or it can include the vitreous cavity, retina, the choroid, supraocular, any part it can be involved. But more importantly, you need to remember, if any physical trauma is there, this is the most common cause of this condition is the physical trauma. The most common cause of this condition is the physical trauma. Or this intraocular hemorrhage, it can be due to any surgery. Like for example, if any cataract surgery is there, in that conditions what we can see, the intraocular hemorrhage can be seen. And these type of the intraocular hemorrhage or the hemophilia, they are associated with diabetes like conditions, hypertension like conditions, or we call the second baby syndromes. So these kind of disease are associated with the intraocular hemorrhage. If we talk about the types of this, the types is based on the location of the bleeding. The type will be based on the location of the bleeding. Based on location of the bleeding. For example, what we have seen, hyphema. So hyphema is if the bleeding is occurring in the anterior chambers. If bleeding in the anterior chambers, we call this condition as the hyphema. It can be the suprachoroidal hemorrhage. It can be the suprachoroidal hemorrhage, where it is just a rare complications and mainly occur due to any cataract surgery or the intraocular surgery. So in this condition, what we see that there is a space between the choroid and the sclera. We call this we call this condition as the suprachoroidal space, and at these regions what we will see, there will be the hemorrhage or the bleeding will be there. It can be the vitreous hemorrhage. Vitreous hemorrhage, when the hemorrhage in the vitreous cavity. It will be the subretinal hemorrhage, or it can be the submacular hemorrhage can be there. Subretinal or submacular hemorrhage can be there. So that you need to remember. So if you see any contusions or these kind of the things, that means the patient will be having, then now when these patients will be having this contusion of the right eye, there is a sudden loss of the visions will be there. And because the sudden loss of the vision is there, because the patients will be having at the particular place. For example, if I say the retina is damaged due to this contusions, so there is a retinal hemorrhage will be there, and now the pupil will react to the light, pupil area will be, everything is looking, but there is a problem with the retina. So that's why we will see the remaining light perception, everything will become the normal, but the retina we know that is involved with the vision. That's why we will see there is sudden loss of the vision we will see in these conditions. Okay, we call that's what intracranial hemorrhage or the hemophthalmia. after that, okay, after that is 65-year-old patients. Now see the history. What you have, 65-year, complain of the pain in the lumbar regions. Okay, moderate dysuria is there. Moderate dysuria is there. Suffering from teeth presentation for half a year. Prostate volume is given. So something related to the prostate. Prostate volume is given. There is a hypoechogenic node in the both lobes. So we have seen there is a hypoechogenic nodes in the both the lobes. The rate of prostate specific antigen is 60 nanogram per liter. Prostate biopsy revealed an adenocarcinoma, which is supplement examination method will allow you to determine these conditions. So normally what we do, we have two investigations, we do the MRI, but in this question we having MRI is not given, that why we will choose the CT, because in this question we don't have the MRI in the option, that's why we will choose the CT as the best option in these questions. So let's discuss this topic in details about the benign prostatic hyperplasia. Okay, so let's discuss the topic, that is the benign prostate hyperplasia. If we talk about the benign prostate hyperplasia, we discussed that the testosterone is there, and the testosterone, if we having the enzyme 5-alpha reductase, if we are having the enzyme 5-alpha reductase, if we are having the testosterone and it in the presence of enzyme 5-alpha reductase, it will be converted into the 1,5-dihydrotestosterone. Dihydrotestosterone. Okay. Then other than that, now if you see this enzyme dihydrotestosterone, it is 20 or 25 times more potent than the testosterones. 20 to 25% more potent than testosterones. What we will see in this type of the conditions, nahi, वो चार लगा दो, ये चार लगा दो. So what you have seen, that there is a narrowing or the lengthening of the prostatic urethra. There will be the narrowing and lengthening of prostatic urethra will be seen. Of prostatic urethra will be seen. Now when we BPH, if we want to know the definition, what we will see, that it is the transitional zone. It is the transitional zone will be affected. In which condition the transitional zone will be affected. The transitional zone will be affecting. What are the clinical features we will see in these conditions? That these patients will be having the low urinary tract symptoms will be seen. Low urinary tract symptoms will be seen in this patient. Along with that, what we will see, there will be the increase of what? Frequency. The increase of the frequency of urinations. So means we call this condition as the, like, more micturations will be there, and this is the most common things that we will see in this person. Along with that, we see there is a nocturia will be there, and along with that we will see there is a urgency will be there and urge incontinence. मीन्स दिस पेशेंट्स went to the washroom, ये वॉशरूम करने गए और वॉशरूम करने के बाद दे ऑलरेडी डिड द यूरिनेशन भी हो गया, ठीक है। उसके बाद भी क्या हो रहा है कि बूंद बूंद क्या हो रहा है इन द अंडरवियर्स, दे हैविंग सम urge, we call this condition as the urge incontinence, we call this condition as the urge incontinence. Like there is some urinations after, like there is some every time they will feel that some urgency is there, every time they feel some urgency is there, and that we will see. And the most it's mostly seen in the old age, like around more than 60 years or more than 80 years old. Then if we talk about the voiding, there will be the retention of the urine, there will be the retention of the urine will be seen. Along with that we see there is a dribbling of the urines. We call this condition again, that is the urge incontinency, the dribbling of the urine will be seen. What the clinical examinations we have do? If we want to do the clinical examinations, we do the digital rectal examinations. What will do? Digital rectal examinations will be done. Then investigation of the choice, if want to do the investigation of the choice, we do the ultrasounds of the abdomen. In the ultrasounds of abdomen, we will check about the volume of prostate. We check about the volume of prostate will be checked. Okay, along with that what we check? We check the serum prostate specific antigen. Serum prostate specific antigens will be checked. Now remember this serum prostate specific antigens, it is responsible for the, this enzyme is responsible for the liquefaction of the semen. This is responsible for the liquefaction of the semen. If we talk about the normal value of these conditions, the normal value will be 0.4 nanogram per ml, 0.4 nanogram per ml. If we have the suspicious of the cancer, if we having the suspicious of carcinoma, so if the suspicious of the carcinoma, that will be more than 10 nanogram per ml, that will be more than 10 nanogram per ml. And if we talk about the advanced prostate carcinoma, if it is the advanced prostate carcinoma, so in that what we will see, there will be more than 20 to 35 nanogram per ml, this volume will be present. This volume will be present. Now if you want to take the treatment also, the treatment, because the treatment can be asked in this question and this is important for other examination also. The treatment, remember, if you having the mild symptoms, if you having the mild symptoms, so the for mild symptoms we give the medical treatment, and what we will give? Selective alpha 1. There is two alpha 1, alpha 1A and alpha 1B. So here we will give the selective alpha 1A blockers, and this will relax the prostatic urethra. That's why they will help to increase the urine flow. They will help to increase the urine flow. What is the selective alpha 1A blocker? Tamsulosin, or we can give the alfuzosin. This is very important drugs that can be asked. So we have the tamsulosin or alfuzosin. In case of the benign prostatic hyperplasia, which treatments we will give? That alpha 1A blocker, tamsulosin or alfuzosin. If we want to inhibit or want to inhibit the growth of the prostate, so we will give the 5-alpha reductase inhibitor. 5-alpha reductase inhibitor will be given, and 5-alpha reductase inhibitors. What is the example of that? That is the finasteride. That is the finasteride or dutasteroids will be given. Finasterides or the dutasteroids will be done. And remember that this finasteride, it reduces the size of prostate. It reduces the size of prostate. It reduces the size of prostate. Remember this thing. The tamsulosin, it increases the urine outflow. It increases the urine outflow. But if we want to inhibit, because we want to prevent the growth also, to reduce the size of the prostate, what we will give the patient, that is 5-alpha reductase inhibitor, finasteride or the dutasteroids will be given. Okay, so I hope you can remember these things. If still this is not the able treatment, if the severe conditions will, this is for the mild one, but if the severe conditions or the severe symptoms will be given, then in that conditions what we will do, we do the surgery. We do the surgery, transurethral resection of the prostate, TURP, TURP. What we will do, the TURP will be done. Okay, is that clear till now? Okay, so this is about the benign prostatic hyperplasia, but here we having the question about the, not about the just benign prostatic hyperplasia, the question was about the prostate carcinoma, because what we can see that this patient is having the prostate specific antigen is 60 nanogram, that crossing the advanced prostate carcinoma also, that's why this is undergoing the carcinoma. So let's discuss the carcinoma also. So if we talk about the prostate carcinoma, if we talk about the prostate carcinoma, so first and the most important thing, this is the most common in the elderly, male or female, of course male, the prostate having the males, the prostate having the males, and most probably we will see more than 80 years old, more than 80 years old, more than 80 years old. Now what we will see, this is arise from the peripheral zones, and in this condition we see the enlargement of the, there will be the enlargement of the posterior lobe, the enlargement of the posterior lobe of the prostatic urethra. What we will see as the risk factor, the first risk factor, this is the age, like if more age will be there, at the more age, more androgens can be there, so there will be the androgen will also a risk factor, the androgen and age, these are the most important risk factors in these conditions. This is the very like the in the world, this is the very slowest growing tumor. If someone wants to get the tumor, and God says that if you want to take the tumor, that is the slowest growing tumor that you can take, and that like it started at the, you can say that around the 80 years old, and then after that also it will be the slowly growing tumor. So that's why it will be not affected so much. It can spread to the locals area like the seminal vesicles to urethra. It can involve the bone particles. There is two conditions. It can also having the metastatics. Okay, if you see the bony metastasis in prostate cancer, the bony metastasis in prostate cancer, in the prostate carcinoma. So what we will see, if you see bony stasis in the prostate carcinoma, this is what osteoblastic, this is the osteoblastic condition. But if you see there is a bony, there will be the bony metastasis in breast carcinoma, bony status in the breast carcinoma. So we call this condition as the osteoclastic, the osteoblastic, or this one is the osteoclastic. If breast carcinoma metastasized to the bone, they are the osteoclastic, means they will cut the bone. And bony, if a prostate cancer metastasized to bones, this is the osteoblastic, means new bony formations will be seen. Okay, so remember these things. For the investigation of the choice, that is the things we need to remember. The investigation of the choice, what we will do, we do the transrectal ultrasound guided, transrectal ultrasound guided prostatic biopsy. Okay, and also we do the one grading here, that is the Gleason's gradings, if you want to remember this, otherwise forget this. Then we will be having the next ones. If you want to having to stage, this is the staging of the investigation of the choice. What we will do, we do the MRI more than the CT scan. I'm writing it there because it's Croc 2. If you want to prepare for further examination, just remember the MRI, that is more than enough. Okay, for the stagings, what we will do, we will do the MRI in these conditions, and which the tumor marker, the tumor marker is the prostate serum prostate specific antigens, serum prostate specific antigens. Okay, that you need to do. Is that clear? If you see the prostate carcinoma, the most common elderly males, more than 80 androgens, more chances of the prostate carcinoma. Bony metastasis in the prostate carcinoma is osteoblastic. Bony metastasis in the breast carcinoma is osteoclastic. Investigation of the choice, what we see, the transrectal ultrasound guided prostatic biopsy, and the Gleason's grading is also seen in case of the prostatic carcinoma. If we talk about the staging investigation of the choice, remember there will be the MRI will be the used for the staging. So here what we can see, which examinations reveals the adenocarcinoma, so prostate cancer is there, which supplement examination allowed to determine the stage of the neoplastic process. So stagings, what we do the MRI, and if it is MRI is not in the options, what we need to choose the CT scan. Okay, because no other options are given in the question regarding the MRI. Put the investigation of choice prostate carcinoma. Hello. Siddharth Singh, क्या वायु voice is breaking, can't hear or can't see presentations. Hello. Now can you, hello, now can you hear? Hello. ये why the students left? Okay, so what we have seen, 65-year-old patients complain of the pain in the lumbar spine. There is a moderate dysuria, prostate volume is 45, and hypoechogenic nodes in the both, 60 nanogram is there, prostate biopsy. So what these questions did you done already? I think. Prostate carcinoma, this is the most common in the elderly males and more than 80 years old. Enlargement of there is enlargement of the, what we have seen, that the prostate carcinoma. So remember the prostate carcinoma, this is the most common in the elderly males, more than 80-year-old, enlargement of the prostatic lobe. क्या दिक्कत आ गई? The enlargement of the prostatic lobes, androgens or the age will be there, and their bony metastasis in the, एक तो बीच में आके ना, we will be having, like we can see that there is a bony metastasis in the prostate carcinoma, osteoblastic. Bony metastasis in the breast carcinoma is there, that is the osteoclastic. So remember, if you having the prostate carcinoma metastasized to the bones, that will be the osteoblastic. If the breast carcinoma metastasized to the bone, that will be the osteoclastic. The investigation of the choice, remember there will be the transrectal ultrasound guided prostatic biopsy, or there is a grading that is used for the prostate cancer, that the Gleason's grading, and the staging investigation of the choice, that is the MRI we will do. If the MRI is not in the option, then you can choose the CT scan. If you want to remember the CT scan, because this is in your Croc 2 exam, that's why I am saying that you need to remember for the CT scan. If the CT scan for other exams you don't need to remember for the CT scan, just remember the MRI. Okay, and the tumor marker is what? That is the serum prostate specific antigens. Tumor marker is the serum prostate specific antigens. Okay, that you need to remember. After that, so here we having the CT, computer tomography, as we can see 60 nanograms, and they ask you the stage of the neoplastic process. So stage of the neoplastic process, we know that the MRI, but MRI is not in the option. That's why what we will choose, we will choose the CT of this. After that, we have seen the X-ray picture. So X-ray picture, the X-ray picture of the chest shows a density and abrupt decrease in the upper lobe of the right lungs. The middle and the lower lobe of the right lungs exhibit significant pneumonization. The right close up to the dense lobe. In the upper and the middle part left, there is a multiple focal shadow. So we have seen focal shadow. The left, there is a clear outline, the two annular shadow with the quite thick and irregular walls. So what disease we having? That is the fibrocavernous tuberculosis. So in this we will see there is a fibrous walls along with the cavity. So these questions we already done. So what is the fibrocavernous pulmonary tuberculosis? The next question 117. So we will be having about a patient's complaint about the impaired far visions. The cataract, did we studied about the cataract? Cataract, did we study about cataract? ये हो गया ना भाई. देखो इसमें क्या है कि इन द फाइब्रोकैवर्नस सिंपल है, तो डायरेक्टली इसमें क्या है, वी विल बी हैविंग, दिस इज द फॉर्म ऑफ ट्यूबरकुलोसिस, form of the tuberculosis, in which what we see, there is a presence of cavity, there will be the presence of cavities will be there, or we can see there is a lots of holes will be there in lung tissues, and they are, as well as what we will see, the fibrosis. The fibrosis means the scarring will be seen, the scarring will be seen, and calcifications will also be seen. The calcification will make the hardness. So this calcification on the X-ray, when we do the X-ray, what we see on the X-ray, what you see, there is a increased density or opacity will be seen. The increased density or opacity will be seen, and the irregular thickened wall will be seen. Okay, that is what is given in the questions. The pneumatization, also remember the pneumatization का मतलब होता है कि air filled space. Pneumatization means air filled spaces are there. So this is the sign of the chronic lung disease. This is the sign of chronic lung disease. Sign of the chronic lung disease. And here in these questions we will be having like the tuberculosis. In the next questions we will be having seen about the cataract. Now see, cataract I think हमने पढ़ा पहले. Pancoast tumor भाई, okay चलो इसको पूरा कर लेते हैं एक बार पहले. The Pancoast tumor, that is also known as the sulcus tumor. The Pancoast tumor also known as the sulcus tumor. Okay, this is the type of the lung cancer. This is the type of lung cancer. Because this question Pancoast tumor, like of the question, they will not ask you. Okay, the type of the lung cancer, and is occur mainly in the upper part. It mainly involves the upper part near the chest walls. Upper part near chest wall. And they affected the nearby structure. They affected the nearby structure like the ribs, the spine, or the nerves, and you will see there is shoulder pain, arm pain, weakness, all type of the symptoms you will be seen. After that, the next question is about the cataract, and the cataract we will be having, there is impaired for visions. Previously his eyes often turns red and the This previously is often red and the eyes are not irritated, the cornea is transparent, antichamber medium deep, they are liquid transparent, everything is there, and crystalline. So biomicroscopy, what we have seen, there is a crystalline lens reveal the area of opacity and the vacuole, so make a diagnosis. So for making the diagnosis, so we know that if you see any opacity in the, if any opacity is seen in the lens, we call this condition as the cataract. If any opacity in the lens, we call this condition as the cataract. Any opacity in the lens, we call this condition as the cataract. Any opacity in the lens, we call this condition as the cataract. The cataract is, remember, this is the most common cause of gradual, painless loss of visions. The most common cause of gradual painless loss of visions. If we talk about the types of the cataract, the type we will be having, the one we having the acquired, the another one we will be having, that is the congenital. The other one we will be having the congenital. Now if we talk about the acquired one, the acquired ones, the metabolic cataract. The metabolic cataract आपने पढ़ रखा है already. Like for example in the Wilson disease, myotonic dystrophy, diabetic mellitus. So these all are the galactosemia. Galactosemia, what kind of the cataract we see? Write down. What kind of the cataract we seen in the galactosemia? The traumatic cataract. After that we can having the complicated cataract, or we can having the age or senile cataract. The age or senile cataract, I think we discussed in the yesterday last class, senile cataract. Then we will be having the congenital cataract, and the congenital cataract, it involves the developmental cataract or the infantile cataract. It involves the developmental, and the second one is what? That is the infantile. The second one will be the infantile. So that you need to remember. अरे यार नेट की क्या हो रहा है? हेलो, did you hear what I told? So which cataract we seen in case of the galactosemia? Which cataract we seen in case of the galactosemia? Hello, which cataract we seen in case of? नेट ही नहीं चल रहा यार मम्मी. Hello, 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 hello. Okay, I was asking, in the galactosemia, which kind of the cataract we will see in case of the galactosemia? Which cataract we will see in case of the galactosemia? Hello. Which cataract we seen in case of the galactosemia? Which cataract? Can you hear me what I'm saying? Hello. To tell me now what's the answer. Which cataract we see in case of the galactosemia? That is the oil drop cataract. Oil drop cataract we seen in case of the galactosemia. Okay, I hope you already remember this. You should remember this about the diabetes mellitus, about the galactosemia, Wilson disease, and there is a Wilson disease. We see the sunflower cataract, galactosemia, oil drop cataracts. The diabetic mellitus, we see the snowflake cataract. So remember these things. Then we will be having the traumatic cataract, the complicated cataract, and the age senile cataract. Then if we talk about the congenital we will be having the developmental, and the second one is what, that the infantile cataract will be seen. Developmental and infantile cataract will be seen. So after that, remember that if we talk about the congenital cataracts, if we talk about the complicated cataracts, in the complicated cataract, remember the complicated cataracts, we see what the most common cause, if you want to say, the most common cause will be the uveitis. The most common cause will be the uveitis, and other cause will be the myopia. Then we see the appearance. If you see, there is a breadcrumb appearance. There will be the breadcrumb appearance with polychromatic lustres. So that is the complicated cataract, and the breadcrumb appearance with the polychromatic lustres we will see in case of the complicated cataract. And the site, if you want to say about the site, the most common site is the posterior subcapsular. The most common site is the posterior subcapsular. So that's why we call this condition as the posterior subcapsular cataract. We call this condition as the posterior subcapsular cataract. Okay, so we will be having here the crystalline lens. So we having seen the crystalline lens. So this area reveals the opacity and the vacuole. So this area of opacity is telling us about the cataract. Why it is complicated? Why we call the complicated? Because this is the breadcrumb appearance. The breadcrumb appearance we see. Now see the question. Now his often eyes turned red and hurt. His eye are not red. Cornea is transparent. Anterior chambers are medium deep. Liquid is transparent. Iris of the eye not change color. The pattern is changed. The pupils irregular shape and the scallop. So what we have seen, only the things is about his eyes often turned red and hurt. The eyes or these we seen in case of the uveitis or scleritis. We seen in case of the uveitis, conjunctivitis. In all these things we will study. And we know the most common cause of uveitis is what? The most common cause, uveitis is the most common cause of which cataract? That is the complicated cataract. Along with that, we see this crystalline lens and in the area of opacity and vacuoles. So this crystalline lens will give the appearance of the breadcrumb. In the question they didn't mention about that, but if they will mention, that will be the easy questions, but they didn't mention, but that's why it will give the breadcrumb appearance, and that's why we will assume that is the complicated cataract. Because other are like example the diabetic cataract, that is the metabolic cataract. Radiation cataract, there is nothing about the radiation. Tetanic cataract bhi kuch nahi hota hai. Senile cataracts we already discussed. In the senile cataract they will give you some history about the patient's age and all. After that we will be having, now this question is simple. There is a pain in the right hand for the 4 days. The pain arose at the side of the cones of the palmar surface at the base of the first and the third finger. Now you have seen that if this is the fingers, if these are the fingers, they are the 4 fingers, and this is the thumb. Now see, if this patient will be having here, if he having some problem, if here we see there is some phlegmons or the subpus formation is there at this region, at the palmar surface. So what we have seen, sometime later the dorsum of the hand became edematic. The dorsum of the hand become, this area will become the edematic. First and third fingers are half bent. When you try to bend these fingers, in the interface, the hands looks like the rake. It looks like the rake. अरे यार नेट नहीं चल रहा यार अच्छे से हैं वो तो चलता ही नहीं है यूट्यूब पे डालनी पड़ेगी। राधे राधे राम पता नहीं क्या दिक्कत है। So what we have seen, if you have seen this hand is there, and at the hand regions what we have seen, that this region, at this regions what we will see, there will what we will see, there is a phlegm or any like bacterial infection is there. So this bacterial infection, the patients will be in the looks like the rake, the patients will be looks like the rake, like this type, the patients will be looks like the rake because of the infection here. If any infections will present here, it will be looks like the rake. The interphalangeal fingers will not able to bend, the interphalangeal finger not able to bend, that's why it will looks like the rake regions, rake like, and that will give the appearance of the rake like. So the hand will, what the most likely, this is due to phlegm of the second interdigital space of the right hand. Okay, is that clear? And these patients will be having some edematic type of the conditions. Now question number 119, a 30-year-old patient had deep burn covering the 30% of the body 30 days. Now he presents with the continued fever, loss of appetite, night sweat. Fever, loss of appetite, B type of the symptom, burnt surface, weakly granulates. What is the stage of the burn disease? Now see, if we having the patient, the deep burn patients, we have discussed about the burn everything. I think, yeah, burn we discussed most of the things, where we discussed the burns degree and all those things we discussed. So that you need to remember. If you see any kind of the burning patient, the first things that will be affected in the burns is the upper layer, like epidermis will be there. Okay. यार क्या दिक्कत आ रही है? Okay, I think it's now okay. So what you have seen, a 30-year-old patient deep burns that covering the 30% of the area. So these questions we have discussed about the acute like toxic epidermal necrolysis, about the acute burning syndromes, then all these things we already discussed. If we see there is 30% of the body, so what we have seen, that it involves the bacterial conditions or the bacterial endotoxins. It involves the bacterial endotoxins, toxic epidermal necrolysis. So we call this condition that the stage of the burn disease, that is the septicotaxemia. These stages, they are the like old classifications. This is based on the old classifications. Based on that, we classified the burn into the burn soak. There will be the burn soak when the patients will be having the first period of the burn disease, and the soak durations will be given. After that, there will be the conditions acute burn toxemia. The acute burn toxemia will be there, and after that there will be the septicotaxemia will be theirs, and this is the burn infections that we will see. And after that there will be the period of reconvalescence will be there. Okay, so remember, just if you having the, like if any the deep burning is there, so there will be the involvement of the toxic surface or the endotoxins will be there, and that will lead to the septotoxemia. Then remember that those what we discovered, the all the burn stages and everything, that is the important ones. But this one, I hope so, this will not be repeated. If they repeated, this will the same questions will be repeated. Other than that, it will be not be repeated. But if that can be the question can be asked from what we studied in during our pediatric class. Then after that, if we see, if the patient is girdle pain in the epigastric area, breathing is frequent, abdominal muscles tense, cytokine blooming signs of peritonitis. So if the peritonitis, yani ki we already know peritonitis. If peritonitis, the inflammation of the peritoneal regions. In peritoneum, we having the have the major or the play major roles in like they have the form the wall of the abdomen. So what are the maximum terms to make the diagnosis? So we will take that just in 2 hours we need to the early diagnosis, require the early diagnosis as early as possible, and that is within the 2 hours. This is the direct question that you need to mug up. So that is if the maximum term to make the diagnosis for the peritonitis. So remember that is the in the 2 hours that is given, and we need to within the 2 hours we need to make the diagnosis of the peritonitis. Just mug up these questions. Direct question has been asked. After that, a surgeon examined a 42-year-old patient, diagnosed him with the right forearm furuncle at the purulonecrotic stage. The furuncle was lynched. Now see, there is a furuncle was there. At furuncle, this furuncle was lynched. मतलब फट गया. ठीक है, this furuncle फट गया. So at the hydration stage, the wound dressings would include the following medications. So at these conditions, what we will give, if this lynched will be, if the furuncle will be lynched, like cut or the फटा हुआ. ठीक है, the फटा हुआ, that is the hydration stage, the wound dressings would include the following medications. So what we will give the hypertonic solutions. What we will give, the hypertonic solutions will be given. Now see, if we having that like any solution is there, in that solutions, if we having some salt is there, like if this salt is there, and around this there will be the water will be present. Around this there will be the water will be present in these regions. Now the water having, if the case of the hypertonic solution is given, hypertonic means more tonic solution is given. So in that conditions, the water will move out of the cells. So hypertonic water will move out of the cells. Now can you see the furuncle? Furuncle is what? That is the hair follicle, the inflammatory parts, and there is a accumulation of the fluids also can be there. If this will be lynched, so first things we need to do, we need to clean that wound, and for the cleaning what we use the hypertonic solution. When we use the hypertonic solution, the fluid that is present inside, that will be moved out of the cells, so all the dirty water will be removed. That's why what we will give the hypertonic solutions. That's why what we will give, hypertonic solutions will be given. Is that clear? ठीक है, after 15 minutes we will take the break. After that, the next questions, because of Verloop disease, what is the name, another name? Idiopathic thrombocytopenic purpura. Most of the questions we already done. ठीक है, so that you need to, that's why you need to just revise whatever we have studied. If you have revised previous things, then definitely you can pass this exam with more than 80%. Okay, not I'm not saying 90%, 90% you can say, like when we will complete the full syllabus. But still, if you have done everything from the pediatrics, from the gynecology, and now from the surgery, then definitely, or the rheumatology part also, then definitely you would be able to finish around 80% questions you can do. Those who didn't do the therapy, if you will try to do the therapy questions, the most of the questions you will see that most of the questions we already done. So we have the Verloop disease. So Verloop disease that you need to do. So what we have the first place for the pre-operational what transfusion medium will be given, that what will give the thrombocytic mass. The ITP, what we studied in the ITP, World Hope disease, immunothrombocytopenic purpura, what we discussed, there is a thrombocytopenia. Yes, there will be the thrombocytopenia will be there. So if the thrombocytopenia will be there, what we will need to do, we need to provide the thrombocytic mass should be given to the patients or the transfused to the patients at the first place. Now if we want to check the necessity to perform the hemotransfusions, who can specify the patient's blood group and research incompatibility? You know, in India anyone can have, like whether it is the normal ward boy or anyone can do this type of the things, but officially it should be done by a doctor of any specialty can do what about the blood groups. He can do check up the specify the patient's blood group, and he can do the research incompatibility also. Whatever the blood group he wants to measure, he it's the doctor responsibility to check that. A doctor of any specialty can be checked. Okay, or like for the such type of the question, if you will confuse between, because देखो this type of the question you will get in the exam for sure, one or two questions or the three questions definitely you will get this type of questions. But for that questions you don't need to worry about these questions. You need to be just open your mind and think logically. Whatever the options, surgeons will take the specify the patient's blood groups. Then is that laboratory physicians, is that anesthesiologist, or is that traumatologist? So everyone can give, but if they already given in the options a doctor of any specialty, that's why we will choose that doctor of any specialty can be chosen, that is specify the patients. So this type of the questions you will get in the exams for sure. And valvular pneumothorax we discussed in the last class, the same question. After that, a victim of the car crash. Now you see there is a car crash is there, so patient will be having the trauma. So in the trauma, what I told that A, B, C, D, E, A, B, C, D, E. If you see these type of the things, A, B, C, D, E, the A for we are having the airways, B for breathing, C for circulations, D for disability, and E for exposure. If trauma patients comes to you, the first you need to check the airway, then breathing, the circulations, disability, and exposures you need to check. After that, you go under the craniocerebral trauma. During examination, symptoms of the focus injury of the cerebrum are found. Cerebrum contusion is suspected. Now this patient having the problem with the cerebrum, so what method of examinations is to be used? Now what you need to do, this patient having the cerebrum contusion. So if any brain pathology you see, the most of the things in case of the brain pathology, you need to do the CT scans. So if the CT scan of the head, you will do more preference than the MRI. If the brain pathology is there, the CT of the head you will be done with the MRI. After that, the next questions, a 35-year female patient was admitted to the surgical department with the symptoms of, now you have seen there is a ulcerative gastric hemorrhage. And we discussed that when we see the ulcerative gastric hemorrhage कब होता है, then we have the ulcers perforations. This is the complications of the gastric ulcers or the peptic ulcers. It's been the third hemorrhage for the last 2 years. Third hemorrhage is given after conservative treatment. Vomiting with the blood stopped. The hemoglobin elevated from 60 till 108. General conditions become better, but profuse vomiting with the blood recurred into 2 to 3 hours. Hemoglobin decreased to 93 to 58. Now see, the patient is under the, like the hemoglobin now firstly after the conservative treatment, again the 60 to the, it coming to the normal. But after that general condition become better after the conservative treatment. But as this patient having the third hemorrhage, again there will the recurrence has been happened. So profuse vomiting will be there with the blood recurrent in the 2 to 3 hours. Again due to there is a blood loss, the hemoglobin will start decreasing, and once the hemoglobin will start decreasing, what we need to do, we need to, of course, whatever I told you that in the Crow 2 questions, most of the times you will get this as the surgery option. Most of the times if you don't know anything, mark this surgery. And this patient is having under the gastric hemorrhage, and now you can see the blood is, hemoglobin is just 5 milligrams. That's why we need to go for the urgent surgery. Okay. After that, a 39-year-old patient complained of the tumor on the anterior surface. Okay, this question we will do after the break. An unconscious victim in the severe condition is brought to the clinic. It is known that the patient touched the bare wire. Now, if the patient has touched the bare wires with his hand and during 5 minutes was under the influence of an alternating current with a voltage of the 220 volts, that is the normal voltage. Physical examination, we see the skin is pale, cold by the touch, breath is weakened, and the blood pressure is 90/50. Now, patient is going under the soak, progressing under the soaks, going to soak. So if the patient is going under the soaks and the pulse rate is 60 by bpm, arrhythmia, then the fields of the necrosis of the skin on the right hands. So what is the preliminary diagnosis? They already make the diagnosis in the question. Now see, there is a bare wire is there. There is a bare wires. So bare wires matlab there is a bare wire is there. So bare wire will be there, and after that we have seen that patient is under the influence of the alternating current. So what we have chosen, now see this kind of the options. Firstly, see the option vascular collapse due to electric current lesions. Now if vascular collapse will be there, the patients will be under the tachycardia. This patient is not. Electrotrauma, that is acute cardiovascular failure. In acute cardiovascular failure, they will give you something, that is a cardiac insufficiency. The patient is not able to having, there is a cardiac insufficiency will be there, or there will be the decrease in the cardiac output, or such kind of the things they will mention in the question. High voltage electroburn of the right foot and the shanks, electroburn of the right foot and the right hands. Now they have mentioned the note the shank in the options. So what they have mentioned, the skin on the right hand and the right foot. So that's why we have choose the electroburns of the right hand and the right foot. Okay, these are the direct questions. Then drumsticks, distal phalanges, these things we discussed where in case of the bronchoectasis. In case of the bronchoectasis. So if any obstructive disorders is there, what we need to do for bronchography? We need to do for bronchography. So for the bronchography, because the bronchography will able to make like how much obstruction is there, and whatever the obstructive disorders, restrictive disorders we already discussed. In obstructive, what kind of the problem will be there? Inspiration or expiration? Please explain which one, Siddharth? 8:35. Okay, I will explain it after the break. Tell me, like in obstetrics, which kind of the problem will be there? Expiration or the respiration? There is an expiration problem will be there, like the COPD, asthma, or the bronchoectasis. Bronchoectasis, what you have seen, the drumstick distal phalanges will be seen. So all these kind of the things we do the bronchography. Okay, most of the questions we already done. Now see, the blood typing results the positive isohemagglutination reaction with the standard serum of A and B blood groups. Now you have seen A, B negative reaction with the serum O and AB blood groups. What is the result indicative of? So I think we discussed about the ABO and the RH blood grouping. Okay, initially we discussed already. So what we are having, that is the faulty standard serum. After that, this question is just a silly question directly, but that can be the possibles if like it is the old things. If the patient having the age 44 is operated on account of the intraperitoneal hemorrhage. Now the patient having the intraperitoneal hemorrhage, in which the case the patient's blood from the abdominal cavity used for the autotransfusion from the same body. Now see, if we having the stomach rupture, according to this question, but I think this should not be in the final exam, but according to this, अगर stomach rupture हो रहा है तो stomach rupture क्या होगा? That will be stored in the peritoneal cavity. And this will be like free from the bacteria. That's why I think we can choose this condition, this blood as the autotransfusion bloods. In all other conditions, the blood will not able to stored in the cavity, and due to there will be the bacterial infection chances will be more. So that's why we will not able to auto transfuse that blood. But if the stomach rupture is there, that is the peritoneal cavity. But again, this is the silly questions. No need to remember, just remember the questions. And if the stomach rupture, peritoneal cavity, auto transfusions will be there. There the two questions is given in the base. Maybe in the initial times when we don't have some all the digital activity or जितनी भी modern activity जो नहीं थी, तो that's why maybe at the previous times, and the croak two persons they believe in the previous one also. Now a man with the stab wound of the right foot applied to the doctors. A stab on the bone with a nail 2 hours ago. So in the patient's medical charts, it is stated that 3 years ago he passed the whole course of vaccination against the tetanus. Now we have seen that this patient has already whole course of the vaccination against the tetanus. So what is the tactics of the doctor to prevent the tetanus in this case? So for the prevention of the tetanus, what we have, they have already, if already vaccinated, no need of further vaccination, no need of further post exposure vaccination. Okay, in case of the rabies we discussed, if the vaccination has been done, then we give the immunoglobulins, and the persons have not vaccinated. In case of the rabies, if the person have not vaccinated or not able to recall whether vaccine is given or not, so in that things what we have to do, we have to give the vaccine also, along with that we will give the immunoglobulins. But in the rabies, if vaccinated is already given, then at that time there is no need of further post exposure vaccination. But in these conditions, in case of the tetanus, we will give the 0.5 ml. Firstly, the 0.5 ml injections, and the whole course, the prevent tetanus. If whole course is given of the vaccination, then further no need to conduct any specific prophylaxis, no need to give any further vaccination. Okay. This question we done yesterday. Ki there is a when we are doing the blood transfusions, so we have seen there is acute hemorrhage and the class 3 blood loss underwent blood transfusion and got 1.8 liter of preserved blood. Now see, they mentioned that there is a preserved blood is there, and erythemas of the same group and RH. After the transfusion, the patients complained of the unpleasant retrosternal sensation. His arterial pressures dropped to 100 to 60 mmHg. There appeared the convulsions. Blood serum calcium was at the rate of 1.7 millimole per liter. What is the mechanism of this complication development? Now see, we have discussed that if the citrate will bind to this, citrate have the more capacity to bind with the calcium and the magnesiums. So in that patient, the free calcium or the free magnesiums will be decreased. That will lead to the hypocalcemia and hypomagnesia. That will lead to hypocalcemia and hypomagnesia will be there. And we know that calciums, they have the important role in our heart. The calcium, they have the important role in our heart. It helps in the cardiac contractility. So that's why it will impair the myocardial functions, and they impair the myocardial contractility can lead to the cardiac problems, or can lead to the further heart failure also in this person. Okay, so if you will get some questions, some history about the blood transfusion or something. Now I told you that we don't use the citrate in the blood transfusions. Previously we used the citrate in the blood transfusion, so that's why what we have to choose the citrate that bind to the calcium ion, hypocalcemia, impair the myocardial function. Then the same questions we discussed yesterday about the complications. The first complications we discussed, that over the pyogenic reactions. The first reaction we discussed about the pyogenic reactions. So whatever the transfusion, this is the early reactions we seen in case of the blood transfusion. The pyogenic reaction or the blood transfusion reactions that we see in case of the blood transfusion. There is the same question about the patient is under the lot of liquid fluid in the abdominal cavity. The patient is found to bleeding from the mesenteric vessel of the small intestine. Damage to the whole organs has not been revealed. So what we call this condition as the auto blood reinfusions. In In this question they ask you in which case we can do the auto transfusion stomach rupture, and in this case condition they ask you opposite of the questions, like there is a liquid fluid in the abdominal cavity, so at that times we can which like what the best way to restore the blood is that auto blood transfusions. Now, if the patient hospitalized with the carbuncle of the upper lips, the carbuncles we told the most common site is the nape of the neck, but if we have seen that it can also be seen in the conditions like there is a upper lips or other regions, the body temperature 39 degrees Celsius, pronounced edema of the upper limbs and the eyelids. So what is the surgeon tactic of the choice? The carbuncles we told that it can be the dangerous complications, and that's why we will hospitalize it into the surgical unit. Most of the question you will say that uh, because they don't choose the minimum for, they just choose the surgeon tactics, because we are studying the surgery, that's why they choose the surgeon tactics only, and the surgeon tactics is the operation or the surgery. I now see this question. Now this question we have seen the stomach ulcers. Now we have seen the stomach ulcer. The stomach ulcer we have seen the complications. The one complication we have seen the post-hemorrhagic amnion. There's another one, the perforated ulcers. Now other than that we have seen there is a treatment in the gastro unit. Had a course in the treatment in the gastroenterological unit. 2 weeks later developed the constant pain. Still he got the development increasing and resistant to the medications. I don't know why they choose the malignizations, but this patient is just resistant to the medications. The abdomen is painful in the epigastric area, moderate defense in the pyloroduodenal area, which complication develop aggravated the patient states. The perforations, it will be not there, because in the perforation we discussed that if the perforations will be there, there will be the chances of the hemorrhage, and there will be the patients can having the some like we discussed in the previous question, there will be the shock conditions or all these things conditions will be there. Hemorrhage, again the same things. Penetrations will be like not use the penetration word. The stenosis, yes, that can be the possibles where the that is the complications we discussed, but these all are the complications are not useful in according to this condition or not suitable for these questions. That's why I think they choose the malignization, because the resistance to medication is there. It is with the if the any person resistant to the medications, we cannot say that patient is malignizations. But this is the croak too, that's why we need to choose such options. Okay, so last questions we will do it after the break. ठीक है. So let's take a 20-minute break at 55. 20-minute break, and after that we will continue with the I think around all the questions we will continue, and because all the questions are mostly repeated questions, so that's why we will able to finish on time.